welcome to all attendees from across the globe. This free initiative from the IMS, the International Menopause Society, is designed to expand healthcare professionals' access to world-class education on menopause and midlife women's health, featuring insights from leading global experts. In 2025, the IMS, in collaboration with its partner societies, will present 8 online symposia covering cutting-edge topics in women's health and menopause. These sessions are globally accessible, ensuring that healthcare professionals worldwide can benefit from the latest research and clinical advancements. Today's symposium, What's Hot? Options for Treatment of Hot Flashes 2025, marks the first event in this series presented in partnership with the International Society of Endocrinology. We look forward to an engaging discussion, and we invite you to join us again for the second symposium, Menopause and Metabolic Syndrome, led by the International Society of Endocrinology on March the 19th, 2025 at 3 p.m. CET. This webinar has been supported, as can be read in the slide, by an unrestricted grant from Bayer. Bayer had no role in the selection process of topics and speakers and has not vetted or reviewed the content of the speakers' presentations. It's time for introductions. I am Antonio Cano, Professor of Obstetrics and Gynecology at the University of Valencia, Spain. I'm head of the Women's Health Department at the Research Institute in Cliva in Valencia. It is my great pleasure to introduce my International Society of Endocrinology co-moderator, Jean-Patrice Baillargeon. Please, Professor.
Thank you, Professor Cano. So I'm Jean-Patrice Baillargeon, Professor of Medicine at the Université de Sherbrooke, which is in Canada. And I'm also on the board of the International Society of Endocrinology. I'm an endocrinologist, and I'm also specialized in reproductive endocrinology. So I'm very much interested in menopause and looking forward to this symposium. Thank you.
Thank you, Professor Baillargeon. So today we are honored to have 2 esteemed speakers with us. Firstly, we have Dr. Marla Shapiro, professor in the Department of Family and Community Medicine at the University of Toronto, who will speak on new drugs and alternative approaches for hot flashes. Dr. Shapiro is professor at the University of Toronto, as I said, and she is a medical expert for CTB. She's also a best-selling author and serves on advisory boards, including the Terry Fox Research Institute. She was president of the North American Menopause Society in 2017 and is on the board of trustees on the International Menopause Society. In 2015, she was named a member of the Order of Canada for contributions to medicine and public health communications. Please, Dr. Shapiro, take the floor.
Hello, I'm Dr. Marla Shapiro, and I'm going to be focusing in this part of the seminar on new drugs and alternative approaches for hot flashes. Here's my conflict of interest disclosure. Well, this audience well knows that vasomotor symptoms are the cardinal symptoms of menopause. Up to 80% of women experience this, with 60% reporting moderate or severe symptoms. We know that they typically last 7 to 10 years, but can be even longer or perhaps less frequent depending on the individual ethnicity or the onset of these hot flashes. And we know that these symptoms have been linked to indicators of cardiovascular disease. We can classify these symptoms as mild, moderate, or severe, with severe meaning that there's enough of a sensation of heat with sweating causing cessation of an activity. If we look at Canadian or North American or international guidelines, they all recommend menopausal hormone therapy as that first-line treatment for vasomotor symptoms, as long as women do not have contraindications. But there are contraindications to the use of either a progestational agent or estrogen, and they're listed here for you. Typically, undiagnosed abnormal vaginal bleeding, a history of breast cancer or other estrogen-dependent cancers, coronary heart disease, active VTE, history of stroke, known thrombophilia, active liver disease, or known or suspected pregnancy. We know that for many women, either with or even without a contraindication, non-hormonal therapy may be preferred. And as a result, there are statements looking at this by each of these societies as well as other societies. Who's a suitable candidate for a non-hormonal treatment? Well, firstly, there are women who would prefer not to take hormones. And even if we see them as candidates for menopausal hormone therapy, a woman who defines herself or self-identifies as not wanting to take hormones, we know she won't take hormones. And then there are women who have a contraindication, such as being older than 60 years or menopause being earlier than 10 years prior. And then many of the things that we just mentioned before as those contraindications. What's interesting, though, is that in a global study of some 1,800 women, where 12% were menopause hormone therapy contraindicated, in fact, 57% of them were eligible for menopausal hormone therapy, but self-identified as being against using it. Now, the evidence for non-hormonal therapy is varied. The Menopause Society in North America has a position statement on non-hormonal treatment that was placed in 2023 that many of us do agree with. What's new is in the green, we're looking at what's recommended with RCT data. And what we have RCT data for is low-dose paroxetine and fezolinetant. Off-label pharmacotherapy includes SSRIs, SNRIs, gabapentin, oxybutynin. We have mind-body techniques, cognitive behavioral therapy, and clinical hypnosis. All of these are recommended. Then in our yellow area, we have those recommended, but with caution. And those include stellate ganglion block, which is difficult to access, weight loss, which may make a difference, pregabalin, which we typically no longer use because of side effects, clonidine and suvorexant, which we also do not use. And then there are other techniques that lack efficacy or have insufficient data, such as cooling techniques, avoiding triggers, exercise and yoga and dietary modifications. While they will do no harm, they're unlikely to make a difference. The same with mindfulness, paced respiration and relaxation, soy foods, S-equal supplements, herbal remedies, and cannabinoids, and the same thing for acupuncture. So there's very little that we have in terms of RCT non-hormonal therapy. In fact, that 2023 position statement looked at where you might be wanting to use some of these, even the ones that are off-label, including most of the SSRIs, SNRIs, gabapentin, and oxybutynin. But now we have a first-in-class neurokinin B antagonist that's approved in Canada, approved in the United States, and in fact approved in Europe. It's known as fezolinetant. Pregabalin, we're not using because of adverse events. Clonidine as well, significant adverse events and no recent studies showing greater benefit than placebo. And suvorexant has limited data. So what have been the breakthroughs in the understanding of vasomotor symptoms that have led us to a new class of medications? And this is a focus on the KNDy neurons. What we've learned is that the hypothalamus is responsible for controlling core body temperature. It is the hypothalamus that triggers our physiological mechanisms to keep the core temperature within that thermoregulatory zone known as the thermoneutral zone. When there are small changes in core temperature, the peripheral arteries constrict or dilate in response to signals coming from the hypothalamus, and they attempt to maintain our core temperature. When there are large changes in core temperature, cutaneous vasodilation and sweating help maintain those core temperatures. But in menopause, with less estrogen and then subsequently no estrogen, we see a narrowing of that thermoneutral zone. As a result, even small changes in temperature trigger cutaneous vasodilation and sweating, which is commonly known as a hot flash, and at night is known as a hot night sweat. Now, the KNDy neurons have had a revolutionary breakthrough in understanding menopause, starting with Naomi Rance as early as 1990. And all of these studies that subsequently came out in 1990, 2007, all the way to 2013, helped us develop the new hypothesis on the mechanism of menopause implicating those KNDy neurons, because what was seen as early as 1990 in Naomi Rance's studies was the hypertrophy of estrogen-sensitive neurons in the hypothalamus of postmenopausal women, and that was when they were first discovered. And subsequently, we have learned that menopause and the human hypothalamus have an evidence for the role of kisspeptin neurokinin B neurons in the regulation of estrogen negative feedback. So let's talk about these KNDy neurons. They live in the hypothalamus and they express neurokinin B, kisspeptin, and dynorphin. I want to focus on neurokinin B because it's the neurokinin B that leads to positive feedbacks to that KNDy neuron at the NK3 receptor. And here in our pictorial, you can see NKB, neurokinin B, binding to that neurokinin 3 receptor. And that is implicated in vasomotor symptoms through stimulation of the thermoregulatory center. Kisspeptin is known to stimulate GnRH pulse essential for reproductive function, and dynorphin gives positive feedback to the KNDy neuron at the KOR receptor, also responsible for GnRH pulse. Now, what would be the role of estrogen? Estrogen offers negative feedback. So estrogen binds to the ER alpha in the same KNDy neuron. Neurokinin B binds to the NK3 receptor. And when estrogen and neurokinin B are in balance, thermoregulation is normal. So in other words, estrogen offers that negative feedback that keeps the NKB positive feedback in check. And that keeps our thermoregulation in the premenopausal period of time within the range that we expected. Now, during the menopausal transition and subsequently postmenopausal, we first have ovarian production of estrogen fluctuating, eventually declining. And it's that decline in estrogen that leads to a loss of that negative inhibition of the KNDy neuron. So as a result, we have neurokinin B unopposed binding to that NK3 receptor, leading to hypertrophy of that KNDy neuron. And as a result, we no longer have estrogen with its negative feedback being present, and we get heat dissipation mechanism with sweating, peripheral vasodilation, a hot flash, or a night sweat. With that reduced negative inhibition by estrogen, neurokinin B production by the KNDy neuron increases. And as a result, the increased neurokinin B creates that positive feedback loop where increasing neurokinin B further disrupts the balance of the KNDy neuron. It leads to hypertrophy of that neuron, hyperactivity of that neuron, and that in addition includes further increases in NKB. So we can see with the loss of estrogen, we now have unopposed hypertrophy of this neuron. The increased signaling of that neurokinin B to the thermoregulatory center activates heat dissipation mechanisms, resulting in a hot flash. So if we think about this elegant science, one can imagine that if we could block neurokinin B from binding to the neurokinin 3 receptor, that we could stop this overstimulation and the hypertrophy of the KNDy neuron. Now, KNDy neuronal pathways have also been implicated in impacts on sleep and mood. Now, here you're looking at the NK1R receptor, and we know that substance P will give positive feedback to the KNDy neuron at this NK1 receptor, also at the level of the hypothalamus, and it may contribute to vasomotor symptoms causing dilation of cutaneous blood vessels. But there's also emerging data suggesting that it may have involvement in sleep as well as mood. So the KNDy neurons have then become a potential therapeutic target. So to summarize, we know that positive feedback by neurokinin B to the KNDy neuron at the NK3 receptor will cause hypertrophy, and that's implicated in vasomotor symptoms through stimulation of the thermoregulatory center. And as far as substance P is concerned, the binding at the NK1 receptor, which is a different receptor, can contribute as well to the vasomotor symptoms, but may suggest a role in mood and sleep. So our first study looking at NK3 antagonist is a study on fezolinetant. The original study design was a 1:1:1 randomization because it tested both 30 milligrams and 45 milligrams. And then at the end of week 2, our placebo group was transferred to 30 milligrams and 45 milligrams and followed out to 365 days. Primary endpoints were assessed at week 4 and week 12. Now, what's come to market is the 45 milligram dose, but in looking at the data, we saw significant improvements through week 12 observed as early as week 1. And as with all menopausal studies, placebo often has a great role, no different when we look at hormone studies or we look at these studies. But we can see that even with the role of the placebo in terms of reducing VMS frequency, it quickly separated very, very quickly as early as week 1, and the primary endpoint examined at week 4 and then at week 12 into significant reductions in vasomotor symptom frequency. The next question was for those that were not aborted in terms of removal of frequency, the ones that remained. In fact, we saw a further reduction in the severity of these remaining hot flashes. And again, primary endpoint at week 4 and week 12 was met. And you can see the greater improvements with fezolinetant 45 milligrams, which is the subsequent dose that has come to market. Now, if we looked at fezolinetant 45 milligrams in terms of PROMISE, this is a questionnaire that assesses sleep disturbance versus placebo. And if we focus on the gray in the placebo and the blue, which is the 45 milligram dose, we can see at week 4 and again week 12 these very significant differences in terms of improvement of sleep disturbance as assessed by the PROMISE inventory scale. The conclusions were that both doses, but again 45 milligrams is the dose that has come to market, was efficacious for the treatment of moderate to severe vasomotor symptoms associated with menopause. We saw significant improvements through week 12, observed as early as week 1, and it was associated with a statistically significant improvement in patient-reported sleep disturbance. During the study, there were no safety signals of concern that were apparent for either dose, and we do have further data on full safety. As it's come to market, we do recommend baseline liver function tests at time 0 before the institution, the first 3 months to monitor when on the medication, and then month 6 and month 9. Now, the dual neurokinin pathway, neurokinin 1 and neurokinin 3, is looking at antagonism at both of those receptors with a new drug in the pipeline called elezinitant that targets pathways involved in vasomotor symptoms with sleep mood disturbances. And this is a different pictorial, but really pretty much summarizes what we've looked at before. And we're looking at blocking the binding at the NK3R receptor and blocking substance P binding at the NK1R. And this antagonism is thought to improve both hot flashes, sleep mood disturbances, and improve the quality of life. Well, we've had the OASIS 1 and 2 phase 3 placebo-controlled double-blind studies, again, postmenopausal women, similar to the fezolinetant studies, age 40 to 65, with more than 50 moderate to severe vasomotor symptoms per week, randomized either to placebo or the 120 milligram dose of elezinitant. And at week 12, the placebo group was re-randomized to the 120 milligram and followed up. And what we saw was elezinitant demonstrating statistically significant reductions in vasomotor symptom frequency, and again in the residual symptoms, lowering the severity, and improvements in sleep disturbances and menopause-related quality of life in both these trials. So this is what it looks like in a pictorial. Here we're looking at elezinitant 120 milligrams in the purple versus placebo in the gray. And we're looking at the mean change from baseline and average daily frequency of moderate to severe vasomotor symptoms over time. And you can see the clear separation at week 1 of the change in the frequency of moderate to severe vasomotor symptoms. And when the placebo group was re-randomized at week 12, they too demonstrate that marked improvement in the reduction of moderate to severe vasomotor symptoms over time. So too, when we look at severity, again, in the purple is elezinitant 120 versus placebo. You can see the clear separation at week 1 and very clear at week 4. Week 12, that placebo group was re-randomized to the elezinitant 120 milligram phase treatment. And again, you can see them approaching our original group that was started with medication right at the very beginning. And if we look at the PROMISE in terms of sleep total scores over time, again, we see that improvement in the elezinitant 120 milligram versus the placebo group. And when the placebo group is re-randomized to the on treatment, they too improve in terms of sleep benefit. So what can I summarize for you? In terms of our good level evidence of non-hormonal options for menopausal symptoms, We have those SSRIs and SNRIs, most of them are off-label, gabapentin, cognitive behavioral therapy, and hypnosis. And now we have on-label, large randomized clinical trials looking at NK3 receptor antagonists, and coming shortly, a dual NK1, NK3 receptor antagonist with large randomized clinical trials. Understanding the KNDy neuron and how we have a change in thermoregulation with the loss of estrogen has led to the very exciting development of these new class of medications and offer for our women who are suffering with significant severe and moderate hot flashes a new non-hormonal treatment option for the treatment of their menopausal symptoms. Thank you for your attention.
Thank you, Dr. Shapiro. Now we will have the second speaker, Professor Herman Depypere. He is a full-time professor and consultant at the University Hospital of Ghent, specializing in menopause and breast clinics. He earned his medical degree and PhD at the University of Ghent and trained in multiple international hospitals. He is a past vice president of the European Menopause Society and the current president of the Belgian Menopause Society. With over 300 publications, his recent research focuses on Alzheimer's prevention with menopause hormone therapy and breast cancer prevention through pregnancy hormone therapy. So please, Herman, take the floor for your talk.
Thank you very much for the invitation to speak, and thank you very much for Marla for giving an excellent lecture. So today I'm going to say something about the standard and other approved approaches to treating hot flashes. So we can see from the elegant research done by Notolovic that if you give placebo, you have a placebo effect on vasomotor symptoms, and the more you increase the dose of your estrogen, the more effective your vasomotor symptoms are suppressed. So what is very informative in these publications and the following publications was that placebo does have an effect, and it's very important to always look at randomized trials. So as Marla already pointed, now we have hormonal treatment, which is the standard treatment for menopausal symptoms. But as soon as there is a contraindication or when women are not willing to take hormonal treatment, then in fact we have now randomized data with KNDy neurons and NK3 antagonists giving very elegant, effective medication. But going back to hormonal treatment, which is still the standard treatment, we know that, in fact, again, if you look at the dosages, the more your dosages, the more it's going to be effective in 90% in a quicker way. So we know these data, and we know that from now, menopausal treatment is, in fact, the most proven and most studied medication. The benefit to risk ratio remains favorable. It's a cheap and ready accessible medication. And of course, we have been confronted with some problems like having more thrombosis and having more breast cancer. But we know, for instance, if we switch to transdermal medication, we can deal with these problems. And it's very important that although now we have new drugs that are very elegant and very effective, we do have to maintain the study on menopausal treatment with hormonal medication, because in fact, we know that if you look at data, these are the data for Belgium, but it's pretty same in every Western country. Since 2014-15, we see that dementia is becoming a very important disease. Well, if we look at added benefit effects that could be potentially there for hormonal treatment, is that if you start early, there may be a reduction. And of course, we know that Alzheimer is one of the most important diseases in the world, and it's affecting more women than male. And we know that ApoE4, which is in fact a factor that is important in the regulation of cholesterol. Well, if you're carrying information to have ApoE4 gene or both genes, then we have about 6 to 12 times more risk of having dementia. Now we have the parameters to measure that breakdown of neurons in the blood. We can measure phospho-tau, we can measure neurofilaments, we can beta amyloid. So in fact, if we do that, we can still see that hormonal treatment away from the treatment of vasomotor symptoms, it really reduces the decline of the brain, especially in ApoE4 women. So just as an example of showing that, in fact, what Toby de Villers also said in his paper, a review paper, he says that we still have to study more on hormonal treatment, which is still the standard treatment for menopausal symptoms, realizing that there is a lot of information still to be gathered, and we have to move down from giving every woman the same amount of estrogen, the same dose. In fact, we should really look in the future to individualize medicine, to look if lean women have an increased degradation of their collagen and their CITX and PMP, then we can really move there to treat osteoporosis in prevention. The same may be happening in a few years with Alzheimer's disease. And if we now currently do a lot of epigenetic training to see what happens in the serum, maybe to detect the women that are at increased risk of having breast cancer, and maybe to reduce the risk of breast cancer as well. So the main thing is that we now are at a very important crossroad where we have, for the first time, a good alternative of hormonal treatment, which is in fact the NK3 antagonists. But we have to acknowledge that the standard treatment, which is hormonal treatment, has safety records of many of 60 years and many millions of women that have been treated with that natural hormone. So we know all the benefits and we know all the side effects, and we are still have to explore how to really fine-tune that medication and to individualize treatments. So if we move to the candy neurons, which have been elegantly explained by Marla, we see that in fact in the hypothalamus there are neurons that have receptors for kisspeptin, for dynorphin, and for neurokinin, and so these have a very important function. They can really have a lot of efferent links to many other neurons, especially in the median preoptic nucleus, where they in fact stimulate the overactivity of the thermoregulatory center. And we know that if estrogen is around, then these cells are normally balanced. If estrogen after menopause is no longer there, then these candy neurons become hyperactive, stimulate too much the neurons in the medium preoptic nucleus, and that results in fact reduction of the terminal neutral zone. So women will experience too quickly that they have a too high temperature, and so that reaction will be to sweat, and this overreaction of sweating and feeling that you're cold is causing the vasomotor symptoms. And now we know that from elegant work of the RANS that in fact these neurons are hypertrophic in postmenopausal women and postmortem sections, but if women took hormonal treatment, this hypertrophy is not present. So as such, these candy neurons were really characterized, and so in fact the first neurokinin antagonist that was in fact done in a trial was pavlinitant, which was studied by a crossover study by Prague and published in the Lancet, showing that this medication was in fact very effective, worked very quickly, but at the follow-up of this medication, it was showing that there was a liver toxicity, and so this drug was no longer studied further. Then we were involved in the first phase 2 study with fezolinetant according to FDA guidelines. So we used the FDA standards to really study that medication, and it was very obvious, like we show now in the follow-up phase 3 studies, that this medication was very effective very quickly. So you have to acknowledge that we studied that medication at twice 90 milligrams per day. So that's 4 times what is now commercialized. And so it was not as a surprise that we had a very effective reduction of the hot flushes severity and the frequency. And so not only the frequency, but also the severity was very quickly resolved. Then we did a lot of other questionnaires, the lead sleep evaluation questionnaire. We had the green climacteric scale, and at all these scales, it showed that fezolinetant was in fact a very effective drug. As soon as week 4, it was very significant, and it went down until week 12. So by the end of the study, a lot of women that were in the study said, please give me that medication because I have never felt such an effective relief of my vasomotor symptoms. So the other thing that was very apparent, that women that had a very effective suppression of these vasomotor symptoms were also the women that had a severe reduction of LH secretion. So clearly these candy neurons have projections in many areas, as soon as also in the pulse generation of the hypothalamus. So in fact, this is a medication which we studied quite closely, especially having the results of pavlinitant that it was liver toxic. We showed that at such a high dose as twice 90 per day, we had no differences between placebo and the fezolinetant. So we had, in fact, more patients having severe, adverse effects in the placebo group. So it's also, if you do a study, it's also always striking that even in the placebo, you have 79% of side effects. So it's really important that the placebo arm is always there. So then it moved on to phase 3 trials. There are, in fact, 2 trials, the Skylight 1 and the Skylight 2. That was, according to the FDA, a requirement to have 2 independent groups studying, in fact, the same questions. So, and the first study was published in the Lancet by Liederman, showing, in fact, in the randomized trial with placebo and the 2 selected dosages of fezolinetant 30 and 45. Then we saw that, as the slides were already presented by Marla, that we have a very clear and a very quick resolvement of vasomotor symptoms. It strikes today that, in fact, if you look a bit closer to the data, you say, but that's not a very big difference between that and, in fact, placebo. But we do have to realize that the reduction is the reduction of severe and moderate hot flashes. These are the hot flashes that interfere with daily life. So these flashes are really resolved quite quickly. And so the mild flashes which do not interfere with daily life is in fact not different. So in fact, this medication is very effective in really reducing the bothersome hot flashes in women. And of course, if you now see the follow-up up to 52 weeks, you see quickly that if the placebo is changed to, in fact, the active group, you see a very quick change from week 12 to week 16 for this medication. So it was very important, again, to look at the safety data for the liver. And so although we have lower dosages as we have used in our first phase 2 trial, so the key inclusion was females between 40 and 65 with an BMI between 18 and 38. And so, in fact, these are the ones, the women that have hot flashes, that have, in fact, 49 to 60 hot flashes a week, though, so very cumbersome flashes. But what is important to me in the discussion, so we moved from something we know that is very effective, we know with quite large trace records of hormonal treatment to new medication. And so, of course, it's important to realize that these studies have been done with exclusion criteria. While if you look at daily life, we prescribe a hormonal treatment to many, many women without realizing that, in fact, some exclusion criteria which were here may not be present in daily life when we prescribe hormones. So like receiving strong or moderate CYP1A inhibitors, well, we don't ask that if we have women that we prescribe hormonal treatment. So in fact, hypertension was not to be present. There was not no history of undiagnosed bleeding, and a medical condition as chronic disease like neurologic, hepatic, renal, pulmonary, endocrine, all those diseases or risk factors were in fact excluded. So in fact, we have to bear in mind that this is a new drug that we will need to explore further as we have it longer in our clinical practice. So if you look at CYP1A2 inhibitors and inducers, we see that a lot of medication that is often used in daily life is inducing or is inhibiting that enzyme. So that may interfere, because if you inhibit it, then it may be that in fact this is accumulation of the drug due to the fact that this CYP is not transforming it properly because you take inhibitors. So it's important to really look, if you look at these data, if you will want to look at that is going to be one of the standard medications to use in women with vasomotor symptoms, we have to look at what are the adverse events. And we see that if you look at placebo and you look at fezolinetant, the low and the higher dose 45, you see that it's very reassuring that in fact these data are not different. So especially if you look at the liver enzymes again, you see that the data again are reassuring. You see that increase of ALT 3 times. It's not much different between placebo and fezolinetant, both groups. So these are the data which were very reassuring, and that allowed the drug to continue and got FDA approval and got EMA approval as well. So in fact, but we do have to realize that we are looking at 175 women, 174 women. So that's still a very restricted number of women, and we do have to be aware that there were exclusion criteria, so they are not the real daily life women we would come across in our daily practice. So again, it's reassuring that from the two studies, the Skylight 1 and the Skylight 2, there were similar results. showing that it was a safe drug, especially as well if we look at the liver enzymes. So bearing that in mind, it is important to say that fezolinetant is in fact a very effective drug, and for the first time we have a very good alternative for hormonal treatment, which is now the fezolinetant, and now we have elinzanetant, which is an NK3, NK1 antagonist, which has been studied in the OASIS 1, 2, 3, and 4, with the OASIS 4 being that drug studied in women that take tamoxifen or aromatase inhibitors. So in fact, the women that have very severe vasomotor symptoms because they take anti-hormonal medication is going to be addressed in that study. The study is closed for inclusion and is now extended for 2 years now. So to have information, because these drugs may interfere with liver, and so it's important to see what happens if you take elinzanetant together with tamoxifen or an aromatase inhibitors, being Femara or Arimidex. So again, it is a study that now has been fairly the same as with fezolinetant, the same inclusion criteria, the same exclusion criteria, and so as already showed by Marla, it is really well studied in placebo-controlled fashion with for 2 weeks, 12 weeks, and then continue up to 1 year now. So you see again, like it was in the first fezolinetant studies, we see that in fact there's a very quick reduction of vasomotor symptoms, and it is in fact as soon as you transform it to the active group, it is very effective as well. So in fact, again, not only causing reduction of the number of vasomotor symptoms, also of the severity of these symptoms. So again, not focusing on the effectivity, because Marlo has shown that very elegantly. It is proven that it is a very effective drug, working very quickly. But then it is important again to look at the safety concerning liver enzyme and concerning other side effects. Well, you see that in fact, if you look at the elinzanetant and you see with the placebo, and you see in the follow-up study up to 26 weeks, then you see that in fact the adverse events are quite reasonable. The only thing that was a bit higher was the fatigue that was more prevalent in the elinzanetant group. So again, it was very well tolerated. The most symptoms were mild and moderate, and there were very few serious events, especially if we look at the liver effect. It was again showing that it was even better than the fezolinetant group. So in fact, it is important to look at these data, and we have now the FDA warnings that as Marla said, that it should be screened at the beginning at 3 months, 6 months, and 9 months after the initiation of therapy. And it's the same if you look at Europe. It also says that we have to check at the beginning at 1 month and 3 months, and then up to discretion of the physician. So what makes me reassured that in fact we have now the post-marketing section showing that there is already 150,000 users of fezolinetant, which is quite much more substantial than the number of women that were included in the randomized trial. So it's important to keep that data, and it's important to be prudent and to see what happens at the long run, because now in the post-marketing section there was a very small number of increased liver enzymes during the first weeks, in women having elevated transaminase. And what is very important as well, as soon as it was stopped, in fact, the problems resumed. So that's not a final or something that is maintained. So in fact, we have to see that after 150,000 users, it's good to be prudent for the next few years to gain more experience on those drugs, which are very promising drugs. And so, of course, we don't have the millions and millions of women that have been taking hormones for more than 60 years. But in fact, it's something we have to build up as clinicians. And so for elinzanetant, there is now 19 trials with 16 completed. So again, a lot of information is gained in this trial as well. So in fact, I think it was my aim to really see what is the standard use now for vasomotor symptoms. I think menopausal hormonal treatment is still very effective, it's still very cheap. There's still a lot of potential that has to be, in fact, screened and detected. And for the first time now, we have a very good, very effective drug that has been well studied in large trial with already a good post-marketing experience, showing that we have a very good alternative in women that can't or do not want to take hormone treatment. So I give the floor back to our president. Thank you, Antonio.
Thank you, Herman. Well, it was an excellent talk, like that of Dr. Shapiro. So now it's time for questions. Just to announce you that we are supposed to have only until 5, so it's still 12 minutes, but I have been told that we may take 5, maybe 10 minutes at most in addition, because there are many questions. And also to announce you that at the end, we will present some slides from the IMS, which are very important and which are very interesting for all of you. So now I will share the debate with Professor Bellerin. So what we will do, we have already prepared that we will share alternatively the questions. So please, Jean-Patrice, would you like to start? There are, you know that there are the questions over here in the questions in the chat that we have here.
Yeah, thank you. Thank you very much for those great talks. It was very interesting, very good view of the treatments of hot flashes and also new treatments. That's great. Maybe the first question here we have on the in the question and answer panel, so you can ask your question there, is regarding polycystic ovary syndrome. Is there any difference? Do you choose differently your treatment, your hormonal replacement therapy in women with polycystic ovary syndrome who go through menopause? That would be a first question.
Herman, why don't you take that one?
So I think polycystic ovary syndrome, in fact, is something that is very prevalent. It is present in about 1 in 8 women in our society. So, but once they are in menopause, it means that in fact there is no more follicles. So in fact the symptom disappears. So I would not treat them differently in menopause as of course differently when they are still in fertile life. So in menopause I would not treat them differently. But I think because they have no more follicles, they will not have an increased androgen level. So I think giving natural estrogen and progesterone will do the job fine, I think.
I agree.
Thank you. Now we have a question from Dr. Cesar Lam. It's for you, Marla. Is prolactinoma and vasomotor symptoms, which combination of hormone therapy do you think might be more appropriate?
Sorry, for what? For
prolactinoma.
Oh, for prolactinoma. No,
prolactinoma and vasomotor symptoms.
Yeah, so I think, again, as Herman has said, we have to individualize these patients. It's really going to depend, you know, what their prolactin levels are, whether this is active, whether they're on medication, to suppress their prolactin. But for many of these postmenopausal women, we can go ahead and treat them as we would any other women. Usually it's going to be obviously individualized and case dependent based on the severity of their disease. But as a general rule, I mean, I'm going to individualize it, and I'm still going to go to my typical armamentarium of medication that I'm going to use. Herman, would you do anything differently?
Yes, I think, from meningioma, it's especially the long-acting progestin like lutein that have been pointed to increase the size of meningiomas, but the natural progesterone is quite neutral for meningioma. But the only thing we can do is treat these women and follow them up and see with an MRI if there is an increase of the size. But I think natural progesterone is in that respect quite safe.
Thank you. It was a prolactinoma.
Yeah, prolactinoma. Yeah, yes. I think the prolactinoma, but for meningioma as well, and prolactinoma is not different. Yeah, not. So these are both things like that's sometimes prolactinoma. Yeah, of course, that we have to see if a prolactin is higher, you have to treat them accordingly. But that would not change the thing. But for the meningioma, it's the same. So I think these are two. Meningioma is more frequent. I think these are the things that we are referred to and see, can we use that, or is that a safe medication? But I think prolactinoma or meningioma, I think these are things we have to deal with and see how they grow or not. And if the prolactinoma grows, we have to give bromocriptine and see how it goes. It should not interfere with menopausal symptoms.
No.
Thank you. And another question is regarding the grading, the scaling of the symptoms. So when you start treatment, you want to know if it's improving the symptoms. And also you mentioned that the neurokinin receptor antagonists are indicated for moderate to severe vasomotor symptoms. So do you use a specific scale? Do you recommend a scale to use for indication?
I think in primary care and in care in general, this is very much the women's report of how it is that they are feeling. And if they self-identify that this is interfering with their activities of daily living, although we had an objective counter because we had to have some objective members to enter into a study, women will identify for me whether their hot flashes are interfering with sleep, with daytime functioning, with in the workplace. So it's not so much that we count a number in my world. And the one thing that I think is very important is that when I go to treat a woman, regardless of what it is I'm treating them with, I tell them that our goal is not zero. We are not getting to zero hot flashes. We are not getting to zero severity because we're not driving the doses in menopausal hormone therapy of estrogen that high. As you saw, Herman showed you those beautiful slides. The higher dose you go, the better results you may get. But what we're looking for is for a woman to come back and say to me, this has made enough of a difference in my life that I'm happy with where I am. So it doesn't really matter to me if I say, oh, do you do these hot flashes? Can you keep on working with the hot flash, or do you have to stop and take off your jacket? If they self-identify as being impaired by their symptoms, we agree that we are going to try, and that the goal is not zero. We want to get to a point where they tell me this is working for me. And usually it's not zero. They still have some hot flashes, they still have some severity, but there's significant improvement. And they are the individual person, which is why we say we're individualizing therapy. We're not talking about, that nonsense of the lowest dose for 5 years. That isn't what we do anymore. We talk about individualizing root dose and formulation if we're looking at menopausal hormone therapy, or if they're contraindicated or self-contraindicated, if we're going to be trying fezolinetant, which is the current medication that's on the market while we wait for, I'm sure, a next medication.
Thank you.
Thank you. Now there is a question here with the links with another one at the end of the list of questions, which is interesting, is fezolinetant in a perimenopausal woman or women in general with sleep disturbances. Might fezolinetant be used to treat?
Off-label, not studied.
Okay, so that was also a bit a part of the question, and then there is another question at the end in which one of the attendees is asking about night sweats. Are there any data about fezolinetant or elinzanetant against the night sweats, independent of vasomotor symptoms, because you know that sometimes some women refer basically that they suffer night sweats. Are you aware of any information of that, or really that is something that has not been studied?
Well, Herman, you can take that, but in the study, we looked at severity of hot flashes and night sweats. We didn't distinguish between whether they were nighttime or whether they were daytime. I mean, certainly the promised data in both studies that looks at sleep, we're looking at, is the sleep improved because of the impact, for example, on substance P, or is the impact improved because it is related to the candy neuron, or is the impact improved because of an overall quality of life because our hot flashes are decreased at night? So that's an answer that I don't know that the data can tease out for you, but we looked at global severity of hot flashes and night sweats. I don't think we separated out whether it was nighttime or daytime.
Thank you.
Maybe
And then again, I think we should be, we are now at the beginning of to use these medication. I think we still have to gain a lot of experience as we go along. I think as we sometimes increase the dose of hormonal treatment in women with severe hot flashes, maybe we will have to learn that maybe some women have to increase the dose. I think that's something we still have to learn. And I think once we are reassured after a follow-up that liver toxicity is in certain women and not thing, I think these are all issues that we still have to gain experience as we use it in daily practice.
And I'm sure all of you will recognize that one of the things that we see as a comorbidity independent of hot flashes and night sweats is insomnia in midlife women. That even if their hot flashes and night sweats improve, many women will still have complaints of insomnia that are associated. So with a new class of orexin antagonists that we have both in North America and Europe, looking at the interplay between orexin and estrogen and progestational agents, this is all evolving, exciting science that we are just, I think, on the cusp of. But I think we do recognize that often insomnia is a comorbidity independent of correcting hot flashes and night sweats. So again, we're going to individualize therapy in our women.
Brilliant.
Yeah, maybe another question regarding those new drugs. Is it possible, do you can foresee that they might be used in combination with hormonal replacement therapy?
We get asked that a lot, don't we, Herman?
Yeah. So I don't think why it couldn't. It could, but something that's never been studied because it was all exclusion criteria. There's no hormonal use. But if these molecules have the same target candy neuron, I think maybe some combination could be something that you have for vaginal dryness, for the bone, or for even for ApoE4 carriers, maybe for protection of your brain, and have a combination for that. So, and then if you have a very low dose of estrogen and a dose of candy neuron, maybe that's is going to be the ultimate goal for breast protection, something like that. So,
we don't know, but the one thing I do want to point out is that for women who have GSM and are on a candy neuron antagonist, we certainly can use vaginal estrogen or prosterone, DHEAS, or any of the other medications that we typically use for the treatment of GSM. That doesn't exclude it. But we did not study systemic menopausal hormone therapy. And this is, we look and we say that the candy antagonist is at the NK3 or the NK1, depending if it's dual. And estrogen will go back into the estrogen alpha receptor. So potentially, but we haven't studied this. So, this is way off label, but exciting science that we may look at down the line.
The thing is, like, if you look at the old data of the Nurses' Health Study, it showed that, for instance, you could give up to 20 years of hormonal treatment in women with a higher BMI and not increasing the risk of breast cancer. So if you have a lean woman with a low risk of breast cancer and you maintain an estrogen level which is reduced but is doing the job, and adding some candy neuron antagonists, maybe that's going to be the ultimate goal. But there's a lot of potential studies that are lying before us and are very exciting to do, I think.
Exciting questions, no answers.
We have to stay tuned.
Now, there is a question it's about hormone therapy in women who start gaining weight with menopause. The question is, is there any combination better than others? I mean, which combination of hormone therapy would you recommend?
Well,
Again, I'll start and Herman's going to end. We know that with menopause, we don't necessarily see weight gain, but we see redistribution of fat just to the centripetal area, which we worry about because it's more metabolically active from a cardiac point of view. We also know, for example, that hot flashes and night sweats are a marker for cardiovascular disease. What we do not know is that if we treat the hot flashes and night sweats, will we reduce the risk for cardiovascular disease? If we treat menopausal symptoms, will we change the distribution of centripetal obesity? I don't know that I have an answer for that. Herman?
We are currently doing a study where we study the effect of giving hormonal treatment or doing active exercise at 60% of your maximum level twice a week, yes, for 45 minutes, or just the combination. So hormonal treatment, active treatment, or active treatment and hormone treatment. And we are looking at what happens to the muscular strength.
Right.
And we do see that active treatment together with hormones seems to be a bit more optimal. So I think that there's a large area of sarcopenia that is still needs to be dealt with. And I think if you increase your muscle mass by doing strength exercise, that will in fact make your lose more weight because you spend more energy because your body mass, body temperature, metabolic rate is better. So I think there's still a lot of studies that need to be done in that respect.
Yeah, we know that as we age, in general, that our metabolic rate decreases and our need for calorie decreases as well. And our need to increase our activity, both resistance training as well as aerobic, but particularly resistance training, is critical for maintaining that lean muscle mass.
Absolutely.
And one of the things that Herman has just pointed out is that word sarcopenia that we're using, that we associate with frailty and risk for fall, that maintaining muscle mass is critical as maintaining bone health. They're different issues, but the muscle mass is best, obtained through doing resistance training and making sure that we're working on that muscle mass. But if we don't do anything as we age, we typically will lose that.
Maybe another question is regarding the price of fezolinetant. So, what is your appreciation of the cost, and also for the countries where it will not be available or not accessible, what would be your best approach for hormonal replacement therapy? So that's the general question. And for a woman with or without hysterectomy. So first, the price, is it accessible? And for those countries who don't have it, do you have a general comment on what would be your best hormonal replacement therapy?
Well, cost is going to be country specific, and different countries have different patient programs that are available to them in terms of supplementing costs for the first month or two and then helping with price reductions. It really depends on your specific country. I can only answer as far as Canada is concerned. So I think that has to be a country specific answer that I'm just not able to give you. And in terms of countries that don't have the option of CANDI antagonists, hopefully that will come to them, because the more options we have for women, the better it is. But again, we're going to look at them on a case-by-case individualized basis. Are menopausal hormone contraindicated? If they're contraindicated, then we're back to that list of non-hormonal options. If they're indicated, then it's really going to depend on their individual history and risk factors to decide whether or not this is a woman that we want to use a transdermal or do we want to use an oral on. And I think that we feel fairly comfortable as science has evolved that low dose oral and transdermals are pretty equivalent initially. As we get older, we may want to move on to a transdermal, but it's going to depend again on that individualized risk more than anything else in the assessment of their cardiovascular risk, their breast risk, and so on. Are they smokers? Are they not smokers? And because it's not contraindicated in smokers the way birth control pills are.
Thank you. Well, there is now one question about potential combination of fezolinetant with anti-obesity drugs, such as phentermine, GLP-1 antagonists, and so on.
Well, they're not metabolized through different pathways. They're not on our list of the CYPs that are interact. So you know, it's like asking about a combination of any medications. You need to look at the drug-drug interactions. Have we studied these? No. But it's the pharmacokinetics and the drug-drug interactions that I would be looking at to see if something's contraindicated. Herman, anything different?
No, I think you're right. I think losing weight and is always better. And if there's no metabolization through a CYP enzyme, so there should be no issue there.
Yeah.
But again, there's no data, no studies done, and that's what I say, that we have to. We have, of course, have a lot of women on hormonal treatment that take these drugs for losing weight, and not real interaction is there. So we have real life, and in these drugs, which are new and we are very safe to move down the path, I think these it will come along as women use that, and it's going to be there in the post-marketing follow-up.
And for me, as a general rule, I don't initiate 2 new medications at the same time.
No.
So, you know, I would be strategizing in terms of what is, and usually for most women, if they're coming to see me and driven by hot flashes and night sweats, that is going to be the target of therapy that we're going to aim at first. And then we can talk about, obviously, lifestyle, the importance of lifestyle, even though, you know, we look at weight loss is not necessarily impacting on hot flashes and night sweats or yoga or any of these things. They benefit overall health. And so we're never going to say no, but I don't institute 2 new medications at the same time, because I can't sort out then, if I have a problem, what I'm looking at.
Okay. Well, we have just time for 2 questions. One for Professor Baillargeon and one for me. And then, because there is a long list of questions, but we don't have the time. So, Professor Baillargeon?
Yeah, short one. So do you, is there any age limit to use these new drugs, norepinephrine receptor antagonists? Can you use them at beyond 60 years old, or is there an age limit?
It's a great question. You know, as Herman pointed out, and I pointed out, what the age criteria were that were studied. But unlike menopausal hormone therapy, where we talk about the window of opportunity and the timing hypothesis, I can't really see that there's a timing hypothesis here. I mean, typically women will come within the first 10 years of the hot flashes and night sweats. And if they're coming to me year 11, 12, or 13 for initiation, I want to be sure that those hot flashes are really hot flashes related to menopause, particularly if they're new onset and not related to anything else. But from the window of opportunity, we don't have upregulation of MMP the way we do with estrogen, which is part of what the window of opportunity and timing hypothesis is. So it's studied up until the ages that you've seen, 45 to 60, but it doesn't have that sort of metabolism that I would be concerned about in terms of an age onset. I just want to make sure that I'm treating the right thing.
Thank you. Now, yeah, the last question is on the exclusion criteria of elinzanetant. Can women with endometriosis, previous endometriosis, I understand, take it?
That's a good question, Herman. I'm going to go to you, because often women with endometriosis in menopause, I'm very cautious about the type of menopausal hormone therapy that I use, because I'm worried about the fact that they may have quiescent endometriomas. But do you want to take this question?
Yes, but I think once women get into menopause, or you have deep infiltrating endometriosis and it has been dealt with, it's very, very rare that you see a lot of women at the age of 48 with endometriosis. I think, but the other thing is that if endometriotic lesions were so severe, and if there's a so deep infiltrating endometriotic disease that in fact everything was removed, the ovaries and the uterus, and women become absolutely menopausal, I think, well, there was no indication that in fact these drugs did anything of stimulation of the endometrium. So I don't think it should be. I think it could be a good medication in the next years after treatment, so that there should be no stimulation of endometrius from endometrium, and so not of endometriosis. I think this has been quite well studied, because we had to do endometrial biopsies and everything like that. But if the endometrium was thin, we saw no stimulation actually with these drugs. So this should not interfere with endometriosis. But again, there is no large endometriotic study with fesoinitant and elinzanetant. So that's something we will have to learn to use in these women as well.
Okay, thank you. So it was a splendid webinar. Many thanks again to both of you. Many thanks to Professor Bellerjon to share with me this job. And well, have a good afternoon. And for you, Marla, and for you, Jean-Patrice, a very good day.
Thank you very much.
Thank you.
Now we have just 3 more slides. One of them to show that the case of the educational activities that are being performed by the IMS are supported by all the affiliates of the society, but include several actions which are read in this slide, as you can see clearly. There are many resources like exclusive offers for IMS members and also free 1-year IMS membership with completion of IMPART Level 1, IMS membership offers in partnership with local regional societies who are members of CAMs, monthly live events, an extensive library of educational resources, and everything maybe find out in the web of the society. And just to conclude, please remember that the next Congress of the Society, the 20th IMS World Congress, will be in Rio de Janeiro, Brazil, in 2026. So you are all invited to come to enroll in this Congress. So many thanks for attending, and have, as I said, a very good afternoon or rest of the day.